You know those moments at the doctor's office, they pull out those seemingly basic tools? Ever wonder what hidden stories they're actually telling about your health?
Yeah, it's fascinating.
Today, we're doing a deep dive into some of those common medical devices, the
Yeah.
ones that offer a remarkable peek inside the human body.
We'll be exploring four really essential instruments. There's the ophthalmoscope, that's for looking into the eye,
Right.
then the otoscope for examining the ear, the stethoscope, of course, for listening to the body's internal sounds,
A classic.
and the sphygmomanometer, which measures blood pressure.
Okay.
And our goal really is to understand not just what these tools are, but how they're used, and importantly, when a healthcare professional would actually reach for each one. Get some practical knowledge out there.
Okay, let's unpack this. Let's start with the ophthalmoscope. That's the one they use to look in the back of your eye, right?
Exactly.
It always feels like they're just checking my prescription, but it sounds like there's way more to it.
Yeah. Oh, absolutely. The ophthalmoscope, sometimes called a fundoscope, it gives us a view of the retina and the fundus, the very back of the eye.
Okay.
What's really special and kind of amazing is that the retina is the only part of your central nervous system we can see from the outside.
Wow, but I don't know.
And the fundus. It's the only place where we can directly look at blood vessels in their natural state, no surgery needed.
So it's like a window.
Think of it
That-
like that, yeah. The back of your eye is sort of like a tiny billboard showing the health of your whole circulatory system. Subtle changes there can be early warnings for conditions affecting your heart, even your brain.
That's a really powerful image. So just by shining that light in my eye, a doctor can get clues about things happening completely elsewhere in my body.
Precisely. Because, lots of systemic diseases affect blood vessels.
Right.
Examining the ones in the fundus can give invaluable information. Plus, of course, it helps us spot eye-specific conditions that might not have obvious signs otherwise.
Like what sort of thing?
Well, we can pick up clues about increased pressure in the brain, certain infections, and even track how diseases like diabetes or high blood pressure are progressing.
Okay, so how does this little gadget actually work? I just remember the doctor getting really close to my face.
Yeah, they do. The most common type is the direct ophthalmoscope. You've got the traditional ones, and then a slightly more user-friendly type called the panoptic, which gives a wider view.
An optic.
Both have a light source, and you can adjust the brightness. Now, brighter light gives a clearer view, obviously.
Right.
But it can also make your pupil constrict, especially if they haven't used dilating drops. And that can be a bit uncomfortable, and it limits how long they can get a good look.
That makes sense. I've definitely blinked a lot during those exams. And I've seen doctors turning a dial, like with different little circles and things. What's that about?
Ah, that's the aperture or filter dial. Think of it like a little carousel setting. It lets the examiner change the size and type of the light beam. Usually there's a medium-sized circle, often marked green, that's good for most exams if the pupil isn't dilated and the room's dark.
And the other settings.
Well, there are larger and smaller circles for different pupil sizes. There's also often a slit beam, like a narrow line of light.
What's that for?
That's really useful for looking at the shape, the contours of the cornea, the lens, and even the retina, checking for any bumps or dips.
Interesting.
Some scopes might have a blue cobalt filter. If they put a special dye, fluorescein, on your eye, that blue light makes scratches or abrasions on the cornea glow.
Oh, wow.
And there's usually a red free filter, too. It uses green light, actually, which makes the red blood vessels stand out more clearly against the background. Better contrast.
It sounds like each setting gives a different perspective.
Yeah.
And what about that little numbered wheel they sometimes fiddle with?
Right, the focusing wheel. That's there to compensate for any nearsightedness or farsightedness either in the examiner's eye or the patient's eye.
Ah, so they're adjusting for themselves, too.
Sometimes, yeah. They might focus on something across the room, maybe 10, 15 feet away, to set it for their own vision before looking into your eye.
Huh.
With the panoptic type, there's usually less need to adjust for the patient's vision unless they have a really strong prescription.
Okay, so the doctor's bringing everything into sharp focus. Now, the big question, when would they actually use this? Is it just standard for an eye check?
It is part of a full eye exam, yes. But it's also used whenever a doctor or nurse needs information for a broader medical diagnosis.
Like what?
Okay, so if someone has high blood pressure, we'd look for specific signs in the retina, hypertensive retinopathy. Things like AV nicking, where arteries look like they're pinching the veins underneath,
Okay.
or little white patches called cotton wool spots.
Cotton wool spots.
Yeah, they look like tiny bits of cotton wool. We also see those and sometimes tiny hemorrhages in diabetic retinopathy. So checking the eyes helps monitor diabetes control too.
Right.
If someone comes in with, say, a really bad headache, we might suspect increased pressure inside the skull. The ophthalmoscope lets us look for papilledema, that's a swelling and blurring of the optic disc, where the optic nerve enters the eye.
That sounds serious.
It can be, yeah. And certain infections, like endocarditis, an infection of the heart valves, can sometimes cause specific lesions on the retina called Roth spots.
So it's definitely not just about whether I need new glasses.
Not at all.
So what's the basic technique? How do they actually use it?
Well, ideally the room is darkened. That helps the pupil dilate naturally. They'll ask you to look at a fixed point in the distance, maybe over their shoulder. That also helps keep the pupil open and stops your eye from trying to focus on the scope itself.
Right.
The examiner positions themselves at your eye level, and here's a key thing. For your right eye, they use their right hand and right eye. For your left eye, their left hand and left eye.
Oh, interesting. Why?
It avoids bumping noses, basically, and they often rest the scope against their own cheek or brow bone, so they move as one unit with it, keeping it stable.
Makes sense.
Then they direct the light into your eye, usually starting from about 15 degrees off to the side, looking for the red reflex.
The red reflex, I think I remember hearing about that. Like in photos.
Sort of, yeah. It's that reddish-orange glow when the light reflects off the retina at the back. Seeing that tells the examiner the path is clear and they're at the right angle.
Okay.
Then they follow that red reflex inward, moving closer and closer until the retina comes into focus. If they lose the reflex, they just back up a bit and find it again.
And where do they look first?
They usually aim for the optic disc first. A lot of important pathology can be seen there. Plus, it has fewer photoreceptors, so looking at it causes less discomfort and less pupil constriction for you.
Ah, clever. And how do they see the rest of the back of my eye?
Good question. With a panoptic scope, they might ask you to look up, down, left, right to bring different areas into their view. To see the macula, the central part for sharp vision, they'll often ask you to look directly at the light.
Yeah, I remember that bit. It's bright.
It can be, for a moment. With a traditional direct ophthalmoscope, the examiner pivots the instrument more, angling it to see different quadrants of the retina, and sometimes, as mentioned, they might use mydriatic eye drops, dilating drops, to get a much wider, better view. They're generally very safe.
Okay. And just to recap, what are some of the abnormal things they might be specifically looking out for?
Well, we mentioned optic disc blurring, which could be papilledema from pressure, or optic neuritis, which is inflammation.
Right.
Those Roth spots and endocarditis. Signs of high blood pressure or diabetes, like the AV nicking, cotton wool spots, or hemorrhages. And sometimes little bright flecks called Hollenhorst plaques can be seen in the arteries. Those are actually tiny cholesterol emboli.
Wow. It's really incredible what they can learn just by looking into your eye.
It truly is.
Okay, let's move on. The otoscope, the tool for looking in your ears.
Right. The otoscope, or oroscope, it's a handheld device, pretty straightforward, used to examine the ear canal and the eardrum, which is technically called the tympanic membrane.
And when is this used? Earache?
Definitely used when someone has ear symptoms, pain, fullness, hearing loss, that kind of thing. But it's also often part of just a routine physical exam.
Why routine?
Well, the eardrum is the boundary between the outer ear canal and the middle ear. So looking at it gives us really important clues about what might be going on in the middle ear space, even if you don't have symptoms right then.
Okay. What are the key parts, and how do they actually get a good view inside my ear canal? It seems pretty small.
It is. A standard otoscope has a handle, usually with the batteries inside, and a head. The head contains the light source and a magnifying lens, typically around 8 diopters, which gives about 3x magnification.
Okay.
And then there's the attachment for the disposable plastic ear specula, those little cone-shaped things. They come in different sizes for different ears.
Right, the pointy bits.
Exactly. To use it, the examiner will gently pull on your outer ear, maybe the lobe or the side or the top part called the pinna.
Why do they do that?
It helps to straighten out the natural curve of the ear canal, making it easier to see the eardrum. Then they carefully insert the speculum-covered end into the outer part of the ear canal.
Gently, hopefully.
Yes, always gently. And importantly, they usually brace their hand, often a finger, against your head.
Why is that?
It's a safety measure. If you were to suddenly move your head, their hand moves with you, preventing the speculum from going too deep and causing injury.
Ah, smart.
Then they look through the lens to see the canal in the eardrum. On many otoscopes, the lens part can actually be removed.
Why remove it?
That allows them to insert small instruments through the otoscope, maybe for removing earwax or a foreign object.
Okay.
And a lot of models have a little port on the side. That's for attaching a small rubber bulb.
For the puff of air.
Exactly. That's for pneumatic otoscopy. Giving gentle puffs of air lets us see how the eardrum moves. That mobility, or lack of it, is really key for diagnosing things like middle ear infections, otitis media.
I remember that puff. A bit of a strange sensation. Are there different kinds of otoscopes?
Yeah, there are a few main types. The most common one, what you'll see in most clinics, ERs, GP offices, is the monocular otoscope. Gives a standard 2D view.
Okay.
Then you have binocular operating microscopes, which ENTs, ear, nose, and throat specialists use. They use larger specula, get a bigger field of view, actual depth perception, and much higher magnification. More for procedures.
Makes sense for specialists.
We already mentioned the pneumatic otoscope, specifically designed for checking eardrum movement with that air puff.
Right.
And then there are video otoscopes. They have a tiny camera on the end that sends the image to a screen, useful for teaching or showing the patient what's going on.
Cool. So when would a doctor decide to use an otoscope? What exactly are they looking for?
Well, the primary reason is to evaluate any ear complaint: earache, pressure, hearing changes, ringing, discharge.
Okay.
It's absolutely essential for diagnosing common conditions like acute otitis media, that's the classic middle ear infection,
Right.
otitis externa, which is swimmer's ear, an infection of the outer canal,
Ah.
eardrum perforations or holes, and sometimes more complex things like cholesteatoma, which is like a skin cyst growing behind the eardrum.
Okay.
They're also looking for simpler things. Is the canal blocked by earwax or ceramin? Is there skin debris, pus, swelling? Is there a foreign body stuck in there? Kids put things in their ears.
Oh, yeah, I bet.
And interestingly, you can sometimes take the speculum off and use the light and magnification to get a quick look inside the nostrils or at the back of the throat.
Huh. Multi-purpose.
And as we said, it's often just part of a routine checkup, screening for any obvious problems.
And what might they see that indicates a problem versus a healthy ear?
Good question. A healthy eardrum should look sort of pearly white or maybe light gray. It should be translucent enough that you might glimpse the tiny middle ear bones behind it.
Okay.
And it should move slightly with that puff of air in pneumatic otoscopy. A little bit of earwax is totally normal too.
And problematic signs.
If the ear canal itself looks red, swollen, or is tender to touch, especially if there's pus that suggests otitis externa. If the eardrum itself is bright red or bulging outwards or looks like it's retracted inwards, those are signs of potential middle ear issues.
Like an infection.
Often, yes. Pain when the outer ear is touched is another warning sign, and a big one is if the eardrum doesn't move with the air puff. That strongly suggests fluid behind it, which is very common in middle ear infections.
I've even seen those little cameras you can buy online to look in your own ears. Are those useful?
Home otoscopes, yeah, they exist. Some parents with kids prone to ear infections find them somewhat helpful just to get a general look. But, and this is really important, they are absolutely not a substitute for a proper medical evaluation by a healthcare professional. You can't diagnose reliably yourself.
Right.
If there are concerning symptoms like discharge, bleeding, dizziness, fever, significant pain, you need to see a doctor or nurse practitioner. Don't rely on the home scope for diagnosis.
That's very good advice. Okay, let's shift gears. The stethoscope, probably the most recognized symbol of medicine, right?
Absolutely iconic.
What is it exactly, and what can doctors actually hear with it?
So the stethoscope is a device for auscultation, which is just the medical term for listening to the internal sounds of the body.
Okay.
It's truly an indispensable tool. We use it to evaluate the heart, the lungs, the intestines, and even blood flow in vessels.
In the purse.
A traditional acoustic stethoscope has the chest piece, that's the bit that goes on the patient. It usually has two sides,
Yeah.
a diaphragm and a bell.
Right. I always wonder why there were two sides.
We'll get to that. Then there's the tubing, which carries the sound, and the earpieces for the examiner. Of course, now there are also electronic and digital stethoscopes too.
What's different about those?
They have features like amplifying the sounds, which can be great in noisy environments, reducing background noise. Some can even record sounds or display them visually as a graph, like a phonocardiogram.
Fancy. But back to the traditional one, the diaphragm and the bell. Why two sides?
Okay, so the diaphragm, the larger, flatter side, is better for picking up higher frequency sounds,
Like,
like normal breath sounds in the lungs, most regular heart sounds, and also bowel sounds. You press it firmly against the skin.
okay, and the bell.
The bell, the smaller cup-shaped side, is designed for lower frequency sounds. You rest it very lightly on the skin, just enough to create a seal.
What kind of low sounds?
Things like certain abnormal heart sounds, S3 or S4 gallops, some types of heart murmurs, particularly mitral stenosis, also sometimes used for listening for bruits in blood vessels. Yeah, like a whooshing sound that can indicate turbulent blood flow, maybe due to a narrowed artery.
Got it. So when and why would a doctor pull out the stethoscope? What are they actually listening for?
Oh, many reasons. For the heart, they're listening to the rate, how fast it's beating, and the rhythm, is it regular or irregular? They're listening for the normal lub-dub sounds and any extra sounds or murmurs in between.
Murmurs meaning valve problems.
Often, yes. Different murmurs can point towards different valve issues. Then for the lungs, they listen over different areas of the chest and back.
What are they listening for there?
Assessing the quality of the breath sounds, are they clear, diminished? And listening for any added sounds like wheezing, which you hear in asthma or COPD, or crackles, sometimes called rales, which might suggest fluid like in pneumonia or heart failure.
Correct.
Listening to the abdomen helps assess bowel activity. Are the sounds normal, hyperactive, hypoactive, or absent? That gives clues about digestion and potential blockages. And as we mentioned, listening over arteries like the carotids in the neck or the femoral arteries in the groin is to check for those bruits, the sounds of turbulent flow.
So it's a really versatile first step in figuring things out.
Absolutely. It provides crucial initial clues that can guide further investigation and testing. It's fundamental.
It seems like just putting it on someone's chest isn't the whole story, though. There must be a proper technique.
Oh, definitely. Proper technique and, importantly, training and experience are essential to interpret the sounds accurately. You can't just pick one up and know what you're hearing.
What does the technique involve?
It involves knowing the right places to listen on the body to hear specific heart valves or lung lobes clearly. It often involves listening in multiple locations.
Not just one spot.
No, definitely not. For the heart, there are at least 4 key areas. For the lungs, you listen symmetrically on both sides, front and back, comparing sounds. Sometimes listening while the patient is in different positions, sitting up, lying down, maybe rolled onto their left side, can bring out certain sounds. And the critical part is learning to distinguish between all the different normal and abnormal sounds and understanding their clinical significance. Like telling the difference between different types of crackles or different pitches and timings of murmurs.
It sounds like a real skill.
It absolutely is. And beyond those core uses, stethoscopes can listen for other things too. Friction rubs over the heart or lungs suggesting inflammation, a succussion splash in the stomach, thyroid bruits, even crepitus, like a crackling feeling under the skin or in joints.
It's amazing the range of information it provides. Okay, finally, let's talk about the sphygmomanometer, the blood pressure cuff. What exactly is it, and why is measuring blood pressure so important?
Right, the sphygmomanometer. It's often just called a blood pressure monitor or cuff. It's the device used, well, to measure blood pressure.
And the name sounds complicated.
It comes from Greek. Sphygmo relates to the pulse, and manometer means a pressure meter or gauge. So, pulse pressure meter, essentially. Its development was a really big deal in medicine. People like Rivarocci simplified the cuff design. And then Nikolai Korotkov, a Russian physician, was the one who described the sounds we actually listen for when taking blood pressure manually, the Korotkov sounds.
Korotkov sounds, got it. What are the basic parts?
You need an inflatable cuff that wraps around the arm. You need a measuring unit, historically, a mercury column, or more commonly now, an aneroid gauge with a dial, or an electronic digital display.
Okay.
And you need a way to inflate the cuff, either a manual rubber bulb with a valve or an automatic electronic pump in the digital ones.
I know there are the manual ones where they use the stethoscope and then the automatic digital ones. What are the main differences in how they work and maybe their accuracy?
Good question. Manual sphygmomanometers absolutely require stethoscope for the auscultatory method listening for those Korotkov sounds.
Okay.
Now, within manual, you had mercury ones. They were considered the gold standard for accuracy, very reliable, didn't need much recalibration. But mercury is toxic, so they're largely banned or phased out in many places.
Right.
The more common manual type now is the aneroid one with the round dial. They're safer, much more portable, but they do need to be checked and recalibrated periodically, maybe every 6 months or a year, because they can drift and become inaccurate, especially if dropped.
Okay, good to know. And the digital ones?
Digital or automatic monitors work differently. They use an oscillometric method. They sense the vibrations, the oscillations in the artery wall as the cuff deflates. They use an algorithm to calculate the systolic and diastolic pressures from those oscillations.
So no stethoscope needed.
Correct. That makes them easy to use, especially for home monitoring or in noisy environments. They usually display systolic, diastolic, and often the pulse rate, too.
Are they as accurate?
That's the debate. A properly calibrated and skillfully used manual aneroid device is often considered more accurate, especially in certain situations. Digital monitors can be less reliable in people with arrhythmias, like atrial fibrillation, or sometimes with very high or low blood pressures. Cuff size and proper placement are also critical for accuracy with digital ones.
And they come in different styles, right? Like wrist cuffs?
Yes, you can get upper arm cuffs, which are generally recommended as the most reliable, but also wrist cuffs and even finger cuffs. Wrist and finger models tend to be more sensitive to body position and potentially less accurate overall.
Okay, so if a doctor or nurse is using a manual cuff on my arm, what are they actually doing to get that reading? Walk us through it.
Sure. First, they choose the right size cuff. For your arm too small or too large gives false readings.
Okay.
They wrap it snugly around your upper arm, usually the bare arm. Position so the artery marker is roughly over your brachial artery, and the bottom edge is an inch or so above your elbow crease. Your arm should be supported at about heart level.
Right.
Then they inflate the cuff using the rubber bulb. They usually inflate it quickly to about 30 millimilli Hg above the point where your radial pulse disappears, or to a pressure they expect is higher than your systolic pressure. This temporarily stops blood flow in the brachial artery.
Okay, gets tight.
It does. Then they place the diaphragm or bell of the stethoscope lightly over the brachial artery, just below the cuff edge in the elbow crease. Now the crucial part. They slowly open the valve on the bulb to deflate the cuff at a steady rate, usually about 2 to 3 millimere Hg per second, or per heartbeat.
Okay, slowly.
Yes, slow and steady. They watch the pressure gauge dial and listen very carefully through the stethoscope. The pressure reading on the dial when they hear the very first clear tapping sound, that first carrot cough sound, is the systolic pressure.
Systolic, the top number.
Exactly. That's the pressure when your heart contracts. Then they continue letting the pressure fall slowly while listening. The sounds might change in quality, a bit muffled.
Right.
And the pressure reading on the dial at the point where the sounds disappear completely, that's the diastolic pressure.
The bottom number.
Correct. The pressure when your heart relaxes between beats. So they note both numbers, 120 over 80, written as 120 80 millimeters of mercury.
And you mentioned carrot cough sounds. Are there different ones?
Yes, technically there are 5 phases of carrot cough sounds described, from the first tap, phase 1 systolic, through muffling to silence, phase 5 diastolic. But for most clinical measurement, noting the first sound and the point of disappearance is standard.
Is there any other way besides listening?
In very noisy environments, like an ambulance, you can sometimes estimate the systolic pressure by palpation feeling for when the radial pulse returns at the wrist as the cuff deflates. But that only gives you the systolic, not the diastolic.
Got it. And why is it so important to measure blood pressure regularly? What does it tell us?
Measuring blood pressure gives us vital information about the force blood is exerting against the artery walls as it circulates.
Okay.
Monitoring it is absolutely essential for diagnosing and managing hypertension, high blood pressure. Hypertension is a huge risk factor for serious things. Heart attacks, strokes, kidney disease, heart failure.
So finding it early is key.
Hugely important. Because often, high blood pressure has no symptoms until damage is already being done. Regular checks help catch it early. It's also crucial for seeing if blood pressure medications are working effectively.
Right.
And in emergency situations or during surgery, blood pressure is a critical vital sign that tells us about the patient's overall cardiovascular status.
It really is fundamental. It's truly remarkable how much information these tools, which seem kind of simple on the surface, can provide about our health.
It really is. You know, despite all the incredible technological leaps in medical imaging and diagnostics, these fundamental tools, the ophthalmoscope, otoscope, stethoscope, sphygmomanometer, they remain absolutely essential for healthcare professionals every single day. They offer immediate valuable insights right there at the bedside or in the clinic.
It definitely makes you appreciate those moments during a checkup a bit more. It's not just going through the motions. It's a skilled assessment using instruments with a pretty rich history behind them.
Exactly right. You can think of them as extensions of the clinician's own senses, allowing us to see, hear, and indirectly feel aspects of your health that would otherwise just remain hidden.
So as we wrap up this deep dive, it really does make you think, doesn't it? How might these classic, trusted medical devices evolve even further in the future?
That's a great question.
With all the advancements in sensor technology, miniaturization, AI, could we see even more detailed, maybe more predictive information being gathered through these familiar tools? Imagine an AI-assisted stethoscope highlighting subtle abnormalities the human ear might miss.
Or maybe ophthalmoscopes that automatically screen for dozens of conditions based on retinal patterns.
Yeah, it's certainly a fascinating prospect to consider for the future of diagnostics.